Good afternoon, everyone. So the topic given to me is surgery in early stage lung cancer. Recently, we saw what is the role of SBRT. It's not moving. So these are the subheadings under which I'll like to cover the talk. What is the early stage lung cancer? Why are we preferring surgery? And if we operate, what should be the approach and the extent of resection? And what is the outcome? And do we stop at surgery or we need something else? Coming to definition, there is no clear-cut definitions. Various papers have given different definitions. So usually it is, T1, T2, N0, and sometime N1. What ESMO says, whatever is operable till stage 3A is early stage lung cancer. This was definition. Coming to the outcome, this is a picture taken from one of a very old paper published in 2006, which says that a screen detected stage 1 lung cancer, if operated, 10-year overall survival is 92%. Coming to recent evidence, AJCC 8th edition, which is a combination of 35 databases, says that operated T1, T2 has got a 5-year survival of more than 70 to 75%. These both papers, the 2006 and the current one, says that surgery has got a good outcome in early stage lung cancer. And so is the recommendation. NCCN prefers surgery as well as the ESMO guidelines. Now coming to how do we approach for surgery. We have open or we have minimally invasive. Minimally invasive again can be video assisted thoracoscopic or it can be robotic. I think here the picture are self-explanatory. Open is obviously associated with a large incision. There is a rib spreader, a significant injury to intercostal nerves. And obviously with picture itself we can make out the short-term outcome differences between these two approaches. So the theoretical benefit that MIS gives is a better vision, sometime 3D if we are doing a robotic. Less of complications because of obviously improved vision, better quality of life because there is a less pain and early recovery to recovery to your routine work, and overall reduced cost mostly because of shorter hospital stay. And obviously both approaches are oncologically equivalent. We have evidences supporting that. These are the two randomized control trials published in 2016 and 18. And they showed that short-term outcomes are better with minimally invasive. There is a decreased procedure time, blood loss, less of an analgesia requirement in minimally invasive approach compared to thoracotomy. Coming to a very recent evidence published in NEJM, Violet trial, this again shows that physical functioning score is better for the first 6 months in a minimally invasive patients. Analgesia requirement is less, pain is also less till post-operative day 2. And looking at the global trend, this is Society of Thoracic Surgery database. From January 2012 to 2014, more than 60% of lung resections were VATS. So there is a good adaptation to this technique. Now this was the approach. Now what is the adequate for a local tumor? In tumor again we have a parenchyma as well as node. So this is a very old paper published in 1995 landmark paper which says that if we are planning for a sublobar resection for a T1N0, outcome is poor. There is an increased recurrence, increased overall death as well as cancer related death in a sublobar resection compared to lobectomy cases. But we have two very important RCTs published. One was by Altorki, which says that wedge or segmentectomy has got an equivalent oncological outcome compared to lobectomy with nodal dissection. There were some issues like more of an air leak in sublobar resection compared to lobectomy, but disease-free survival and overall survival were equivalent. Another paper published in Lancet, that is JCOG 0802, Asamura and colleague, they also said same thing. There is a little bit increased air leak with segmentectomy compared to lobectomy. Here there was no wedge resection. It was all anatomical segment compared to a lobectomy with nodal dissection. What interesting thing was that they also found improved survival in a segmentectomy group. They could not explain exactly what was the reason for improved survival, but they attributed that we are able to save more of a parenchyma in segmentectomy group. That may be one of the contributing factor for a better survival. but there was an increased local recurrence also, but they could salvage it. I'm not sure what was the exact methods of salvaging those local recurrences, because that detail has not been published or come up in the paper. But again, as I said, air leak was slightly higher in a segmentectomy group compared to lobectomy. Another important factor that they were trying to look into is the PFT differences, but they did not find a significant, or the cutoff that they aimed for, they did not find that significant difference in a pulmonary function test in both groups, segmentectomy or lobectomy. So segmentectomy, so far current evidence is only for less than or equal to 2 centimeter, clinically N0 and peripheral disease. Intraoperative, again you have to send nodes for frozen, and if it becomes to be N plus, you have to convert to lobectomy. So peripheral less than or equal to 2 centimeter and N0 disease, segmentectomy has a role. But problem is that all segments are not simple. Some of the segment like segment 6 or segment 1+2 or lingula or remedial lobe, those are a simpler segment compared to complex like basal segments. So segmentectomy has an indication, but it need expertise and little technically challenging procedure to do. That was about parenchyma. Coming to the note, we have important RCTs, and there is a meta-analysis of these RCTs, which says that there is no significant complication difference in a systematic mediastinal lymph node dissection versus sampling. But only thing is that if you are doing systematic dissection, you can prognosticate patient better, and obviously staging, you get a better idea about the staging. That is why systematic mediastinal lymph node dissection is preferred compared to sampling. Coming to the post-operative outcome, again I have taken a snapshot of two important trials. One is of 2011 ECOSOC trial, where more than 1,000 patients were included, and most of the surgeries, that is more than 90% of surgeries, were thoracotomy. Their mortality was around 1.37 with morbidity of 38%. Coming to the current evidence, that is JACOC trial, where more than 1,000 patients were included, and most of the surgery, that is more than 90% of the surgeries, were minimally invasive, that is VATS. They found mortality of 0% with morbidity of 26%. So what I want to say is, whether it is open or minimally invasive procedure, morbidity and mortality are not that high with lung resection. Coming to our own data of uniportal VATS, from 2017 to 21, we had more than 100 uniportal VATS resection, and with perioperative mortality of 0.9% with morbidity of 13%. This was all about surgery and the outcome, but as we all know, as the stage advances, outcome goes down. Whatever said and done, the local recurrence rate is around 50% even in early stage lung cancer when they are followed up for 5 years. So can we stop at surgery? There is always a need to improve outcome even in early stage lung cancer. As the stage advances, obviously systemic therapy has a better outcome, but only systemic therapy is giving a survival advantage of only 5%. That is why there are various other studies and trials that has been done to look into other novel therapies, that is immuno as well as targeted therapy. Checkmate 816 is a trial with neoadjuvant nivolumab, whereas Checkmate 671 and IMpower are adjuvant immunotherapy. ADURA is a trial that I think we all are aware of the results in EGFR positive patient with adjuvant osimertinib. They have shown a better event-free, progression-free survival. Pathological complete response with neoadjuvant immunotherapy is significantly better. OS data is still to come with immunotherapy, but these are methods with which we can improve the outcome even in the early stage lung cancer. So at the end, I would like to conclude by saying that surgery is still the standard of care, and we should prefer minimally invasive if we can get a good oncological clearance. Lobectomy with systematic mediastinal lymph node dissection is still the standard. Segmentectomy has a limited indication and need expertise. But yes, unmet need persists, and we need to look into that. Thank you.